Hello, everyone. Um, we're going to talk about our work, a paper which we title as The Invisible Work of Maintenance in Community Health, Challenges and Opportunities for Digital Health to Support Frontline Health Workers in Karnataka, South India. I'm Naveen, and we have Nervo.
Paula.
And this paper is co-authored by Zainab and Nicola, Paula, Swati, and Deirdre, and is funded by the MRC-HRC Global Public Health Partnership Award Scheme. Next, please. So as is with anywhere else, but definitely India is one of the most important case studies where the public health is running mostly because of the work done by the frontline health workers, such as ASHA workers, Anganwadi workers, or the nurses. Till recently, till the pandemic hit, the amount of work done by the frontline health workers was not commonly known in terms of the public consciousness, and the pandemic has brought forward a lot of it has made visible the amount of work done by the frontline health workers, but it also we are motivated by the desire or the need to make their work visible for policy making, but also in particular when it comes to the design of digital technology in support of frontline health work and community-based healthcare. And our case is looking at the work done in the context of pregnancy care.
As Naveen said, the pandemic has actually made visible the important role that frontline health workers have in order to support healthcare infrastructures. So traditionally, healthcare infrastructures have been looking as a physical thing, as you can see from many different domains, but rather than looking at infrastructures as a physical thing that is readily available for us to use or for something to operate, we consider infrastructure as a highly relational concept that as it becomes infrastructure in relation to organized practices, right? So in healthcare, infrastructure relates to all the physical, social, spatial, and material arrangements of people, routines, places, artifacts, and all the human and non-human entities, including technologies and all the arrangements and configuration between these elements to support and sustain the healthcare practices at all levels of the healthcare infrastructure. So in CSCW and ACI research, there have been some research understanding the human and information infrastructures in healthcare, looking into the social and material arrangements. There have been also research about the home, the municipality health settings, community health settings outside the hospital, right? So the frontline health workers are often less visible, but are really important in order to support community health. This includes community health workers, volunteers, health extension workers, and community social service providers. So the frontline health workers usually deliver counseling and health education programs to support early identification and registration of new pregnancies or any other disease, and also making referrals. So there have been some work in digital health in order to support the work that they do, especially with videos, mobile technologies, but they have been focusing mostly on supporting the educational programs and supporting the accountability of the practices that they do, right? So we are trying to look more into the invisible work of community health, and we are looking into the maintenance work as a form of articulation work that is going to support the continuous efforts required in order to bring together these continuous elements and getting things back, right? So maintenance, we look into this concept as the mundane labor that goes into sustaining the function of efficient infrastructures. So we're looking into the maintenance work, we're actually looking into how community healthcare infrastructures take place through the notion of maintenance. Without understanding this, it's impossible actually to design digital health technologies in order to support all the different practices that take place. So we started a case study trying to understand the care infrastructures in Karnataka state in South India. So particularly, we started the study in rural and semi-urban areas of Channapatna town. You can see in the left side, which is part of the Ramanagara district that belongs to Karnataka state, based with the help of Maya Health, which is our local collaborator. So we conducted different household interviews and also different focus groups with different types of frontline health workers. And you can see, based on the initial workshop that we have with them, we actually find out the important role that they have and the important role of the physical, human, and digital infrastructures. So now we're just going to summarize the findings.
Thank you. So our findings, we structure them across three major themes, all looking at what is the work done by the frontline health workers in order to put together and make this infrastructure work. One major chunk, one theme looks at the work done by the frontline health workers in maintaining the data infrastructures, as well as in anticipating and upkeeping and taking care for the ad hoc demands on their care activities. The second is focusing on maintaining relationships within their own network of frontline health workers, as well as to maintain relationship with the community to build trust and deliver value, but also manage perceptions. And finally, and more importantly, is the work done in order so that they maintain themselves as humans. Next, please. So we will not, of course, go through all the details right now, but we invite you to read the paper and have following conversations. But we structure the findings according to the case of a pregnant woman with complications, because that brings forward a multiple instances of work done by the frontline health worker. Next, please. So, for example, so one of the works that the frontline health workers have to do is to anticipate additional care demands on their work. The state wants them to do a lot of door-to-door surveys for data collection, but at the same time, they do know that the pregnant women and their household expects them to help them navigate the infrastructure, the care infrastructure. So that's why whenever they go to do household visits for surveys, they carry a urine pregnancy test, and if and when they find pregnant women in any household, they start talking to them and advising a pregnancy test, or even advising them to take to the primary health center and getting them registered on the mother and child tracking system. So again, this idea of reconfiguring the job roles imposed by them in order to make it much more easier for them and the pregnant women. There's also another facet to the anticipating and upkeeping ad hoc care activities, which is trying to mend the gaps in the system, again, which arise due to ad hoc demands in the care. And this is one instance of an ASHA recounting an incident, and I'm going to just read the quote here. There was once one case where I had taken a woman for delivery. It was a C-section case at the Chenpatna hospital, which is a Taluk health center. That day, however, the sister, who is a junior health assistant, was not there. Otherwise, probably she could have managed things. The pregnant woman's blood pressure had gone high, because of which we had to go to Mandya, which is about 40 kilometers from Chenpatna, and which is a district tertiary hospital, as per doctor's recommendation. We had to stay in Mandya for 3 days. I couldn't locate the sister at that time, and the high blood pressure of the pregnant woman was difficult to manage. Now, this ASHA worker had to leave behind all her other activities, care activities, including personal activities, and go and stay with the pregnant woman in Mandya for 3 days, as well as taking care of the high blood pressure, which leads to the work done by the frontline health workers in order to maintain themselves, their families, and their expectations and perceptions of the community. And a lot of that work of maintaining is also about trying to track their work in order to push back and then gain the incentives that is their part of their rights. So they, for example, I'm reading this instance by an ASHA worker who says, we accompany the woman to the THC for the procedure, and usually they take these women in an auto rickshaw. And for every such instance, we get 50 rupees if we do everything for the patient and then send them back in the auto rickshaw to their homes. And then when we go and get it, so they have to go and get this procedure entered into the data system at the data center, they get 50 rupees more. But we spend almost 60 rupees to come and go from our home sometimes. And she laughs, which just shows that for every 100 rupees, often they spend 60 rupees. And it is also a lot of work in order to make track these and get these data entered into system in order to gain that much of amount of money for the work that they've already done. So what we propose as a discussion is this change of perspectives of looking at frontline health workers as maintainers and system builders. And we propose the idea of a maintenance center design, where the role of design is to make the maintenance practices visible enough for a legitimization of policy and technology, and to help them reconcile multiple perspectives, values, and expectations between themselves and the community, and finally to help support the coordination mechanisms in the community health. Next, please. This work was possible thanks to our funders, but also to Maya Health, whose health navigators were co-researchers with us, and Design Beku, Manipal College of Nursing, and Bangalore Baptist Hospital, who offered us expert help. Thank you. And if you have any questions, please drop us an email and we will take this forward.
Thank you. Bye.